time. So good morning and good afternoon. I'm so happy that we have some people in diaspora who have joined us. Dr. Okogu, thank you very much.
Thank you.
Dr. Oshodipo, thank you for joining all the way from the UK. Gladstone Irewele, thank you for joining from the US. I want to thank all of us for creating time to be here this afternoon, stroke morning, depending on where you are in. Today, we would like to discuss something that usually most pediatricians don't talk about. I'm sure most of us, when we see such cases, once it's not very clear cut, we just say refer to the dermatologist. But with us today is Dr. Tunde Odusote, a very good friend and a brother, a pastor, who has decided to share his knowledge with us. I mandated him and he had no choice but to be here today. So I'm so happy, Tunde, that you are going to share your knowledge with us today. I also want to thank Dr. Oshinaike, who has agreed to moderate even at very short notice. Thank you very much. So without wasting much time, I'd like to hand over to Dr. Mobolaji Lawal for the usual presidential talk before we start. I hand over to you, sir.
Okay. Thank you very much, Sandy. It's a pleasure for me to welcome everyone again, all the participants so far, and in particular, the guest speaker today, Dr. Odusote, and also the moderator, Dr. Oshinaike. I thank Dr. Iletu for his untiring effort. And it's a pleasure to say that this topic today is a very interesting one because, like Dr. Iletu said, it's very common in practice. Many pediatricians come across it, and I don't know how many know exactly what to do, apart from referring to dermatologists. Also important is the fact that some of our mothers in our community here don't even think that it is a problem for you, the pediatrician. They have their own solution to it. It comes under the general something of ELA in Yoruba. I don't know what they call it in other tongues. And they have their own solution to it, which is traditional. You know, they have traditional soaps and traditional, what they call agbo, I don't know, what do you call that, agbo, which they use, and they have so much confidence in that. So sometimes the pediatrician picks it up as an incidental finding, and then has to now convince the parent to take our own kind of treatment for it. So it's very interesting, and I look forward to learning new things from Dr. Odusote, who is an authority in this area. What is new about atopic dermatitis? So I welcome you all, and I want to listen to Dr. Odusote very keenly. Thank you very much. Dr. Letu.
Thank you very much, sir. I want to formally welcome Professor Grange. She's joined us all the way from the US. Welcome, ma. Good morning. So without wasting much time, Dr. Oshinaike, please go ahead as the moderator.
Thank you, the President, and thank you, the coordinator, Dr. Letu. I'm going to just give us a brief overview and then give us some housekeeping rules, and then Dr. Odusote will come on in no time. Atopic dermatitis, as Dr. Mobolaji Lawal rightly said, it's quite common in our practice. In fact, the literature refers to it as the commonest non-infectious disorder of the pediatric dermatology group or practice, with an estimated prevalence of about 50%. So, in other words, out of every 10 cases you would see in the dermatology consult, atopic dermatitis will be half of those number. Though it's quite common, unfortunately, it's also one of the badly managed dermatosis we see in the pediatric age group. unlike Dr. Letu's experience of willing to ship of atopic dermatitis as quickly as possible, and maybe that's your experience. Our experience at the dermatology end is also one of the badly managed. The reason being that it has so common differentials in fungal infection, and as it is with very unskilled and not so detailed pediatrician or general practitioners, they then go ahead and just throw in the triple therapy of antibacterial, antifungal, and steroid, hoping that one of the three will catch. Those who are smart, who have the child's interest at heart, like most of the pediatricians on this platform, would make a quick referral to the dermatology as quickly as possible. And so that is the reason why atopic dermatitis would remain a condition of interest to those of us in dermatology practice. And this afternoon, as Dr. Mulagilawal has rightly said, there are very few people I know of within this country who is qualified to talk about management and the principles of management of atopic dermatitis as Dr. Olatunde Odusote. Dr. Odusote is a pediatric dermatologist and allergologist with the Lagos State University Teaching Hospital Department of Pediatrics. He is the current acting director of clinical services and training as well. He is a fellow of National Medical College of Nigeria. He holds a specialist certification from the College of Medicine of South Africa. He also has an MPhil in allergy and immunology from the University of Cape Town. He is the co-founder of the allergy and asthma clinics in Lagos, and he's the founder and the chairperson of the Allergy and Clinical Immunology Society of Nigeria. It is with great privilege this afternoon I want to invite to the mic or to the virtual podium this afternoon, Dr. Olatunde Odusote. He has 40 minutes to get through this course and this conversation, and after which we'll have a 10 minutes period for question and answer. But while he's speaking, you can go ahead if you have questions to ask and just put them in the chat box. We'll try and keep track of them so that we can throw in a question as soon as it's time for the question and answer. Once again, we welcome you this afternoon. Dr. Odusote, over to you, sir.
Thank you very much, Yemi, for that kind and generous introduction. And I want to say thank you to everyone on this platform, my teachers, our fathers, mothers on the platform, who paved the way for all of us to be able to practice pediatrics and also encourage us to fly and do what best to provide care for children of this environment. So what I'm going to talk about is atopic dermatitis, what is new. I'll start by defining atopic dermatitis. And I will say to you, atopic dermatitis is a chronic pruritic inflammatory dermatosis that affects primarily children. So it's common in children, but affect adults. And this definition, I want you to please keep it in mind, because one of the reasons why we don't have data that supports the fact that it's common in this environment, because the people who are actually looking after this condition were primary physicians, and when they put their data together, they tend to, you have a skewed data that will suggest it's not a common disease in our climate. So by way of epidemiology, the prevalence of this disease actually appears to be rising since Second World War. And depending on where you look, the rate varies from 10 to 20% in children, and other populations about 3%. And this experience of rising since Second World War is also pertinent, been reported in Nigeria. So if you look at the likes of work by Dr. Alabi in Ibadan, Professor Olumide and George in Ibadan, Olumide in Lagos, you see that from the early data collected, you see a rise in all the population in our climate. But even in their own documentation, you still think it's still a rare condition because there was a mixed bag of adults and children that they looked at together. And it's also pertinent to know that there's inverse relationship between the prevalence rate and age. So the older you get, the rates are actually the prevalence rate is on the decline. Majority of sufferers will have remission by adolescent age group, and that's very key to note. But the truth that you can't tell who will have remission in adolescence and who will still have very severe disease when you see them for the first time. So if you look at the ISAC studies that was done in a lot of countries, including Africa, you found that for age 6 to 7, the prevalence rate was 7.9%. And I want to say that even Nigeria participated in this study. And in South Africa, the essential prevalence rate is about 17%. So if you look at the study that I actually carried out for my part 2 dissertation, which is a clinical-based study, hospital-based study, the prevalence rate was 15.5%. And a study done 10 years later by Pudicom also reported a rate that's higher than 15%. So we still see that there's a problem here, and it's not as rare as we commonly believe it's rare. And if you look at Western literature before now, they will tell you it's very rare in Africans, but it's not really true. It's a common condition. So when we look at what are the factors that are responsible for dermatitis, so things that I can look at that can be risk factors, you find that family history of atopy, either asthma, atopic eczema in the family, or allergic rhinitis, it's a risk factor. So if you have that kind of history in any family, you need to look closely for this disease entity. It's also believed that if you have mutation in the filaggrin gene, you are likely to have the disease. And then the past gene hypothesis was actually one of the things that was put in place. It has still some truth about it, but it's not all the truth. And this is one of the reasons why they believe that even if we are in Africa, because we believe that a gene hypothesis says that if you are dealing with a lot of disease burden, like infection and all that, your T2 immune system is on holiday, but your T1 is driving, is fighting infection. And so if you are raised in a very identical environment in farmland, the chances are low, which is, there's some truth to it, but that's not all the truth. And if you are from isomic class or small family size, is believed is risk factor. And then the quality of the water, if you have carbonated water, then you have risk factor, you have the risk to have atopic dermatitis. So these are some things that are pointers to things they need to look closely to your patient if they have these factors. So in terms of prognosis, I would say to you, it's multifactorial, it's complex. And nowadays, we're actually still teasing out what it is, but there are things that we know that holds true. One is the genetic factor. So if you have a genetic tendency for atopy, that's a red flag as well. But even if you have that tendency and the environmental triggers are not there, then you can still escape as well. And I think that's one of the reasons why we need to, one of the research areas how to modify the environment and prevent people from having allergy or dermatitis. And I will allude to some of those things that have been done during the course of discussion to prevent people from having disease or to mitigate disease or prevent the disease in some children or population or at-risk population. But the truth is that we are not successful. We are still struggling, but there are a few things that we can do that will prevent other severe disease or mitigate the disease. But the current thing that people talk about, so it's like we have what we call inside out or outside in mechanism. So the current thinking is that there's a combination of inside out and outside in mechanism that is driving the disease process. So the outside in is the barrier dysfunction. So in the past, we think the skin is just a layer to prevent invasion of foreign organisms or study as homeostasis to maintain temperature. That is all true. But the new information that we have is that actually the skin or epidermal layer actually participates actively in its mechanism. And I will also allude to that. But the things that we need to know that the filaggrin gene, that one of the things that was first reported as the marker for atopic dermatitis is true, but not everyone. Like a study that was done in South Africa that even some of the Black people they don't have mutation of filaggrin gene, but they have the disease. The SPINK5 also is thought to be involved in barrier dysfunction. Now, what SPINK5 does is to ensure that the shedding of the skin is not rapid. But if you have lack of this SPINK5, with a genetic disorder, find that you shed your skin rapidly, and that will make you vulnerable to outside invasion. So the barrier dysfunction is thought to be part of the process. So if you have a barrier dysfunction, you are vulnerable. The other thing is the immune dysregulation, which is inside out. So basically, people who have atopic dermatitis have decreased their T-like receptors. So these are T-like receptors are things that like for signaling. So you pick up those signals and then you do what you need to do. But if there's a decrease in T-like receptors, then you are not able to function maximally or mount appropriate response. The active microbial peptides, in people with dermatitis, that the antimicrobial peptides are supposed to protect the skin is also lacking. Then you have the exaggerated T2 response, which is the arm that drives your IgE-mediated response. So they found that people with dermatitis have exaggerated T response to a lot of things. Then the newer thing, which I'm sure down the line, the what I call the new kid on the block, and I will talk about the biologics that's been developed to help with allergy, generally speaking, and then the atopic dermatitis is thymic stromal lipoprotein. I'm sure a lot of us in pediatrics we know that the thymic stromal lipoprotein is involved in thymus, where there's some maturation of the T cell memory. But beyond that, this chemicals is actually involved in driving immune response. And I would, like I said, I will allude to what we're looking at in terms of pathogenesis. So the basic information now that is a combination of barrier dysfunction and the fact that there's some immune regulation. And that means that you have to have these two conditions to drive the disease process. So what I want to just do here, just to give you an overview, what we believe, what we know that once you have an antigen, you have the antigen presenting cells, then your T helper 2 cells, and then you drive your interleukin 10, 13, interleukin 15, axon B cells. You have your switch, class switch, and you produce IgE, mast cells, and that's generally applicable to all immune response. But that's the. But now this is the common. This is the new thinking. Like I said, the barrier function, apart from preventing invasion from invasive organism or water loss and stuff like that, that they actually participated in the onset of immune response, innate immune response. So you have things like interleukin 25, IL-33, and TSLP. TSLP, which I alluded to, actually one of the functions are that when you have immune destruction by allergen, it actually enhances the activity of antigen-presenting cells. And then if you block this, then you are like, there's drugs that have been developed to block this pathway so that you can mitigate immune response. These two, interleukin 25, 33, there are also drugs being developed along these lines. What this does, apart from regular pathway we know, they can actually produce all these cytokines from non-B or non-T cells. And then there's a new kid on the block called IL type 2, interleukin ILT type, innate T cell type 2 rather, that even that is also known to drive immune response. And this IL-25 type 3 can act on innate lymphocyte type 2 to cause immune reaction. And that's not related to mast cells and the regular pathway where we know. So these are things that we need to understand, that in atopic dermatitis, we have a lot of things being put in place. And I also say some few things that I also think we need to, which also bring more confusion to the old melee. So in the past, we believe that is it 2-2 half that drives atopic dermatitis. But we now know that if you have chronic atopic dermatitis, there's a combination of T1 and T2 immune response. And that is what people are looking at. But fortunately for us, and I will allude to it, a lot of this atopic dermatitis can be controlled using using basic therapy. But we also need to understand that there are some who have very severe disease that are driven by T2 and T1 and the combination of the two. I can even say that even among the Asians, they have actually done studies that even their atopic dermatitis actually look like psoriasis. And that also brings another dimension to outman disease. But like I said, a lot of the cases we will see can be managed by basic treatment, and I will focus on that. But I don't feel I should share thoughts about where we are going, where we are at this time, and the future of atopic dermatitis and management that will be specific using the new keys on the block. And if you can block those pathways, maybe we're able to produce better results. So in terms of clinical prevention, let me say, number one, diagnosis of dermatitis is strictly clinical. There's no rule as such for biochemical or biopsy. So don't just talk about what we need to know. So in terms of clinical prevention, number one, be very wary to make a diagnosis of atopic dermatitis in a child less than 2 months. More often than not, what people call atopic dermatitis is more like seborrheic dermatitis. But I can say from my experience, there's a thin line between the two, but I would say for a pediatrician, don't be in a haste to make diagnosis of atopic dermatitis before 8 weeks of life. More often than not, you might be dealing with a child with seborrheic dermatitis, infantile seborrheic dermatitis. There are 3 stages of disease that we recognize as infantile type that are called before the age of 2 years, then childhood type between the age of 2 years and 16 months, 16 years rather, and then adolescent type or adult type that occurs in older age group. So these 3 diseases have their peculiar distribution and the way they present. I will emphasize, be wary to make a diagnosis of atopic dermatitis in a child less than 2 months of age before 8 weeks of life. So in the infantile type, what you tend to see is more acute phase of the reaction. You see a lot of pruritus, you see erythemas, you see vesicle, you see exudation, you see crossing. So you see the acute stage usually in the younger age group. But the older they get, then you see subacute to chronic manifestation. So you see a lot of pruritus, you see dry and scaly skin, you see like indication, featuring, escoriation. Occasionally you see erythematous papules. So the thing that in younger age group, you tend to see the acute phase, and the older they get, you tend to see subacute and chronic phase of the disease. So like I said, clinically, you need to diagnose this disease using clinical parameters. So it's mainly a clinical diagnosis. So one of the working party came up with this idea that can be used in the clinic and that can also be used for epidemiological studies. So you have a child that has a pruritic rash. So pruritic rash is mandatory. So if you have a child without the pruritus, is not likely to be atopic dermatitis. So pruritic rash with any or more of these features, we have history of rash in the skin creases. And in this working party diagnosis, skin creases includes the cheek, the neck, the buttocks area, the regular cubital fossa, popliteal fossa are considered to be skin creases. So we have issue of rash in those areas. Then you have a personal history of asthma, allergic rhinitis, or or a family history of atopic dermatitis. So that is there. More often than not, all of them have dry skin in the last 1 year. So most people with atopic dermatitis will have a very dry skin. And then you can use onset before the age of 2 years in any child that's less than 4 years. And visible flexural dermatitis, so you have to look for the rash itself. So either you want to have a pruritic rash with any 3 of this, then you can confidently make a diagnosis of atopic dermatitis in that child. And in my study for my part dissertation, we actually looked at this criteria. And we see that the sensitivity of this criteria in Nigerian child is about 3%, specificity is about 98%, and the positive predictive value of this parameter is 92%. So it's a very reliable tool that can be used in the clinic or can be used in epidemiological studies. So if you ask me, practically speaking, if I see a child, I look for pruritic rash, then dry skin, history of atopy, onset before the 2 years in a child that's less than 4 years, and I look for evidence of the pruritic rash in any of flexural dermatitis, in any of the common areas of prediction. I'll show you a couple of pictures that will bring the message home. So number one is this, you can see this child actually digging into his skin. And you can see that the skin is very dry. And compared to the auntie that brought the child to the clinic, you can see the skin is very friendly and looking nice. But you can see this child digging into the skin. So this is a child with infantile dermatitis. You can see the hair, you can see the generally dry skin. You can see redness around here in this child. And there's some of the minor criteria. You can see what's called, this is called Denny-Morgan fold. You can see it here. And this is one of the markers that you see in ATOPIC, generally speaking, asthma, allergic rhinitis, and stuff like that. But for emphasis, just to look at the cheek, and usually infantile type, you tend to see, this is really all mark of this. You see it at the cheeks, that is like red and angry looking. And then sometimes you look at behind their hairs, you see escoriation. So that you tend to see, and they tend to have dry skin. What I want to emphasize is that in a child with infantile type dermatitis, eczema or dermatitis, they tend to involve the extensor area of the body. You can see this child has a rash at the wrist. The other part is not very visible, but I can tell by our faith it's not a rash around here. But this just to show you a child, the flexural area at the wrist, and then some on the cheek in this child. So this child has infantile dermatitis. So if you look at this childhood pattern, basically what I want to show is a child is a bigger child, more than 2 years. He has involvement of the cubital fossa. What you see here is the acute on chronic kind of reaction. You can see it's still, there's some redness and the liquefaction of the skin. It's also involving the armpit, and the same child has involvement of popliteal fossa. This is due to, some of our people here believe that if you have a rash, you must use irritant to make it go away. So this child has involvement of cubital fossa, popliteal fossa rather, in this child. So it's this kind of thing you see in the child, but you can see it's acute on chronic, and you can see lichenification in this child. So this is to show you that in a bigger child than 2 years, you can have the typical pattern. So this child ideally should have involvement of the flexural, like cubital fossa, popliteal fossa, but you can still see involvement of anterior knee that you expect to see in a child less than 2 years. And the same child has involvement of the buttocks. So if you see this child, you think he has contact dermatitis are very affecting the buttocks, but it's the same child that has the rash, and then the other things fall in place. Then this is to show you that sometimes when you are growing your disease, they tend to now have something like shoe dermatitis or contact dermatitis in the bigger child. Sometimes when you tease out the history, you'll find that initially they have full-blown atopic dermatitis, but as they are growing their disease, they can have what look like contact dermatitis added to a couple of things. So how do I assess severity? There are many tools available for the trade. So you can use CORAD, you can use eczema area severity score, but in the clinic, I think this is more user-friendly. There are pictorial tests, simple questions, you can measure severity. And it's also useful sometimes for your patient to actually assess severity so that you can track their progress, right? So when they come, you assess severity, and then when they come follow up, you compare the score before the first consult, follow up, and that can be something that you can do over time, and you can assess, you can have some form of objective way of assessing progress and whether they're doing well or not. And then this can also help you to be able to objectively assess whether compliance is good or not. You can say, I'm using my medication, but they are not getting better. So when you see very poor score, then you can now say, well, I need to look at what they're doing that is right or wrong. So in terms of evidence of severe disease, how do I think that you need to look for to see, does the child have a severe disease or a mild disease? So if you have widespread area of dry skin, or severe itching, like the picture of that young child that I showed you dig into his skin, or you have a skin thickness or scoriation like lichenification, you see bleeding and oozing, like you have oozing will suggest secondary bacterial infection, or the child is miserable, he is not able to sleep at night and all that, then you know that you are dealing with very severe disease. And then you need to assess, and that's one thing we don't really do rationally. I would say I'm also partially guilty. We don't assess the psychological impact of this disease. Some of these people, sufferers, actually have very difficult with their self-image, and then you need to assess that and actually intervene actively and not overlook that. Then loss of sleep at night is also very important. We need to assess that in some form. I can say to you that the poem that talked about assessing some of this domain about their perception, night sleep, and all that, and that can give you an overview of what is important. So I would suggest that if you manage a child with atopic dermatitis, apart from making that diagnosis, which is clinical, you need to find a formal way of assessing what is going on. And I recommend the poem for every patient looking after a child with atopic dermatitis. So what is principle of management? I will spend more time talking extensively about this because I believe that for all of us, some of us can make that diagnosis, but this is an area where we can struggle a bit. Number one, you need to educate the parents or the child, if he's able to understand what you're saying, about, number one, what's going on. And you need to educate them about your goal of therapy. What do you want to achieve? Basically, what you want to achieve is control. You're not providing cure. And you need to say that from day one, that your goal of treatment is to control severity and that you're not providing cure. It's not like malaria that you can take away or pneumonia you can take away. So the principle is educate them about what's going on and what you want to achieve, the goal of treatment. Number two, you need to avoid external irritant. There are things that can irritate the skin. You want to avoid that. For example, if they're using detergent, you ask them to use non-bio detergent, especially people who use washing machine. They should avoid woolen clothes. All their clothes should be 100% cotton, no wool, no polyester, because wool can scratch the skin or irritate the skin. Polyester will make them sweat, and the chlorine in the sweat can irritate the skin. I put question mark before house dust mite and food. But I will speak to food. A lot of us tell children with allergy, especially to avoid food. The evidence suggests that if you avoid food that is not necessary, you are setting them up for food allergy in future. There are a lot of studies, that the lip study done in the Western world, in UK in particular, that actually said to the fact that if you don't expose children as risk to food that they don't need to avoid, that you are setting them up for maybe peanut allergy in future, egg allergy in future. So for atopic dermatitis, the right question to ask before you eliminate any food is that if you take any of this food, do you have immediate flare-up within 5 minutes to 2 hours of your symptoms? Or do you have hives? Do you have angioedema? Your chest close up or stuff like that? If the answer is no, don't eliminate the food. Let them continue to eat it. That's the lesson about that. So don't just say, and I've seen people refer to my clinic where they said, I saw a doctor that said, avoid all the food, avoid peanut because you have atopic dermatitis. It's not true. Ask a specific question. If you take this food, do you have a flare-up of symptoms within 5 to 2 hours? Because true food allergy will, driven by IgE, will produce those symptoms within that time frame. If the answer is no, then they don't need to avoid the food. If they say to you, if I eat this food, in 3 days later, I have symptoms, at best, it will be non-IgE driven symptoms. And if it's not one of those things like F-pies and all that, they will ride the season. So don't need to eliminate the food. That's what I would say to you. Then the other thing I want to, that people also tend to do is the food, what we call food allergy might just be irritant. So if you have a raw skin and your food rubs on the skin, that will cause irritation. So that's not true food allergy. That's the content irritation that is going on. And I think we need to also look at that. We use antihistamine in management of atopic dermatitis, not because antihistamine has a role in mitigating the disease. We tend to use the type 1 antihistamine because we want to sedate the children. The purpose of using antihistamine for management is to sedate the children. So that we need to, so the fanciful one like loratadine, ketotifen are not useful because what you want is class 1, your chlorpheniramine that will sedate the children and use that at night to make them have improved or better sleep quality. Bathing, to bath, not to bathe, I would say bathe, but use soap substitute in any child. So things like aqueous cream, Sebamed, or any of our black soap that without additives are good. So bathing is useful, but tend to use soap substitute because our soap is alkaline. You want something as close as that will maintain the pH of the skin to about 5.5 or around that area. So use soap substitute, and that is perfect. Bleach bath or vinegar bath. Vinegar bath is common among the American dermatologists. Bleach bath is more common in Europe. The whole purpose of bleach bath or vinegar bath is to reduce the bacterial load on the skin because Staph aureus can act as a super antigen that will drive the process. Or if you have second bacterial infection, then you find control is difficult. So what we tend to do You can do bleach bath, you can do vinegar bath to reduce the bacterial load on the skin. Then wet traps. The key thing about wet traps is when you do wet traps, number one, you prevent access to the child to scratch the skin. Number two, when you do wet traps, you also increase absorption of steroid, which is one of the major tools that we use. Then I mentioned psychological support in children with atopic dermatitis. Well, I need to advance this. So what's going on? I think, sorry, I want to advance. Okay, sorry. So my slide. So in terms of specific treatment, my screen is acting up now, but so in terms of specific treatment, the key thing is still steroid. Steroid. So they don't need to be afraid of steroid. You can use steroid safely in dental practice, and we use fingertip unit. I will speak to that because I'll show you a slide how to use fingertip unit. So steroid is still the mainstay of most of the atopic dermatitis we'll see in our practice at Paediatrician most of the time. So steroid is the key thing, and when your patient has steroid phobia, you can tell them, I will empower you using the fingertip unit to deliver the appropriate dosing without overusing steroid. And then the second thing is we use immunomodulators like tacrolimus and promucolimus. The only drawback to this is they're very pricey, they're very expensive, but they are not as good as steroid. So one of the things I think all of us need to do as pediatricians managing skin disease is to have in your collection, on your material, as we call it, a range of steroid. You must have a mild steroid, things like 1% atrazine cream, and an ointment of cream. But I'll say to you, ointment is preferred because that also provides some occlusion. So you have that as your entry-level mild steroid. You must also have in your material a moderate potent steroid, things like betamethasone, things like I tend to use Elocon, memotazone, because it has a good safety profile. So any moderate potent, and then you can have a very potent steroid, right? And I'll show you a slide that talks about that. So if you have moderate, mild, and potent steroid in your material, I will talk about how to modulate, how to use that. So for example, if I have a child that has a very mild disease, the hell of acute without any infection, I'll probably use a moderate steroid on the face. Usually on the face, I use mild steroid. But neck downwards, if it's not a severe disease, I use also a mild steroid. But if I'm seeing a liquefaction, if it's an older child, I will try and eat as hard as possible. I'll use a very potent steroid within a very short period, and I'll step down to a moderate potent steroid. So the principle on the face for most children, use very mild steroid. Your 1% cream or ointment on the face. From neck downwards, you can use moderately potent steroid depending on the thickness of what they're dealing with. So for some of our parents who have steroid phobia, what I tend to do is to start with steroid and get them how to use steroid properly, and then I can step down to tacrolimus, and usually most of them will be very fine. But let me say, one of the things I do, I think for most people, education is the key. And I'll talk to your fingertip unit. Then the other thing I will speak to is what we call intermittent therapy. For example, you have some areas of the body that are very recurrent or recurrent. So one of the things you can do is that those areas, once you have control, then you can twice a weekend, or either fortnightly, or depending on how the recurrent, like you are trying to do controller medication. So you have areas that are recalcitrant. What you need to do for weekend, Saturday, Sunday, apply the steroid or tacrolimus to those areas, maybe fortnightly, once in a month. So that way, the fact that you don't see any changes on the skin doesn't mean you don't have an active disease. So areas that are very recurrent or active, difficult to treat, you'll have more flare up. You can touch up those areas either fortnightly, monthly weeks. And that's what we call intermittent therapy, and it's very useful. Emollient, let me say there's no perfect emollient for anybody. The perfect emollient is the one that the patient prefers or likes. So don't try to force your emollient to anybody. So the one that the child says I like, or the parents like, or they will apply. There's no point prescribing an emollient that is not used. The key thing about emollient is that you want to trap moisture, and you want to provide some barrier over the area of skin that's been damaged. So emollient is also important, but let me say this, steroid is still the key thing to use, using your fingertip units, and then emollients will be like an adjunct where you are trapping moisture or you are providing some barrier. So this just to say to you what I tend to recommend. So you must have a weak steroid like hydrocortisone. You can have a potent steroid like betamethasone, or mildly potent steroid like I think this is available in the market, tiprednisolone as Advantan. But if you ask me, my preference is methazone. It's a potent steroid, but the safety, side effect profile is very close to weak steroid. So even sometimes if I need to put steroid on the face of the child, I probably will do this because I know this is safe. But unfortunately, it's not very common in the Nigerian market, but it's a very safe steroid. So I tend to use this a lot in my private practice and if I need to see anybody privately. But you need to just have a potent steroid, a mild steroid, and then a very potent steroid. This is available in this market. Clobetasol is available in the market. So, but for your patient, just have that potent steroid, mild potent steroid, and then you do what you need to do. If it's very severe, use mild steroid. Very severe disease, you can use very potent steroid. But the key principle is that for face and occlusive area, armpit, groin area, please avoid potent steroid because absorption in those areas are very severe. And if you need to use it, you need to be very careful for a short period. So these are the fingertip unit. What you're doing from this interphalangeal joint to the tip of finger, that's your fingertip unit. Or this is a chart, but it's not very, the rule of thumb I will tell you is that if you have a fingertip unit, the fingertip unit should cover twice the size of the palm of the person applying the steroid. So what you need to do, like you do for burns, estimate the areas of the palm you can get on the lesion, active lesion, and then estimate the fingertip unit of steroid you need to use. And that will be a guide. So if you empower your patient to use fingertip unit, they can use steroid confidently without underdosing. And then, like in every other chronic disease, you have a roadmap, when to step down, to go up and all that, and they can do that confidently. And for most educated parents, I find that this is very useful. So, like I said, a lot of our patients that you see in your practice, steroid, emollients, and preventive things I've talked about will suffice. But in case they have very difficult cases, things we can look at will be for therapy, but for therapy is only useful in older children, 12 and above. Systemic steroid, I will advise against in children. But in adults, occasionally, when they have genetic disease, you can do systemic steroid. But let me also confess to you, sometimes I do what I call cheat code. Ideally, in public setting, I don't have bed space to admit patient. So if I have a child that's very bad, that I believe require admission, that I need to have steroid with wet wraps, and I don't have bed space. So I do what I call the cheat code. I'll give low dose steroid for about 1 week and say, see me in 1 week's time. But at the same time, what I tend to do, I ask them to moisturize their skin. So why do I ask them to moisturize their skin? So that they can get to a habit of applying topical agents. So once they now get off that steroid, I start topical steroid using fingertip units, and then they tend to do well. So immunomodulation, sometimes we have a very difficult cases, and I would say for my practice, I've not had cause to give methotrexate, cyclosporine, or MMF. I've not had cause to do that, but it's something that can be useful. The new thing on the block is dupilumab, which is anti-IL-4, and so IL-4 and 13. It's very useful, is approved by FDA to be used, but the problem, for some strange reason, if you use dupilumab in a child with atopic dermatitis, you must watch out for evidence of severe keratitis. So more often than not, what people will do is to ask the optometrist to assess their site, and if you see I don't know. I hope I didn't stop talking for a long time. I'm really very sorry, but I don't know how I muted myself.
No, we can hear you.
Okay. So for therapy, steroid for adults alone, well, I say I do some cheat code. Then dupilumab is useful, but it's very pricey. But if you need to use it, one of the major challenges is the fact that they have severe keratitis. So you need to ask the optometrist to evaluate them and you must also report evidence of keratitis. The other thing I talk about, TSLP, anti-IF25 and 33, is not yet, they're still under, we're still looking at them, but it's not being FDA approved. So if I have a difficult disease, a refractory disease, so two things, you need to assess adherence. Are they using the medication as prescribed? You ask them, the question to ask is, how often do you forget to use the medication? Don't say, do you use the medication? I say, I use it. But you can say, how often do you forget to use your medication? Or show me how you use your medication. Or describe how you use your medication. So these are things, so poor compliance, adherence, and incorrect use of medication can be reason for your poor results. Then again, if you have staph infection, like I said, staph can act as super antigen. Super antigen means that it can bypass your mast cells and still drive the immune response. Viral infection can also make things very difficult. Then triggers like emotional distress, exposure to irritant like a sweat, wearing rough clothing, then using soap instead of soap substitute, overeating, indolence or dry skin. These are things that can make control difficult. I would say food, I want to say food. Don't eliminate food in all your patients. You must get the right history. If you're in doubt, refer to an allergist to evaluate your child. Then wrong diagnosis. So if you are not getting results, then maybe you have made the wrong diagnosis. And there are things that, okay, so prognosis. 50% of the people who have disease that will resolve in puberty, but you cannot pick which one will resolve. Then the other thing that disease is rare in middle age. So if you're making diagnosis of nothing middle age, then you need to think twice. There are other things. I don't want to go into all that, but there are other things you need to look at. But fortunately, we're all pediatricians. So middle age is not a problem. So most of them tend to have that disease. But there's things you need to see. If you see those things, then you know the prognosis is bad. If you have very severe disease in childhood, this starts early in life, and there's family history of atopic dermatitis, like in nuclear family this time around. And if there are set other atopic tenders like asthma, rhinitis, or food allergy, then you know you are dealing with very bad disease. And for some strange reason, being a female can be an issue with their symptoms. So what is a major, if there's anything I want to take home from this presentation, is number one, atopic dermatitis is a clinical diagnosis. So you don't need to do a biopsy, because if you do a biopsy, what you see in atopic dermatitis, what you see in contact dermatitis is the same thing. So, and another thing I want to point out is that please, I want to beg of you, don't do total IgE in any child with allergy or any allergic condition. It's useless, except you are thinking about some other disease like your BPA, ABPA in asthma, or you think that hyper IgE syndrome. So if you are dealing with that, then don't do a total IgE for asthma, for atopic dermatitis, for food allergy. They are useless. And I also want to beg of you, don't do food panel for every child with atopic dermatitis. History is important. And I will emphasize history. If there's no flare-up of symptoms after taking food between 5 to 2 hours, there's no need to do food panel for IgE, because allergy test is garbage in, garbage out. So topical steroid, I'm going to see the mainstay. For most of the people that you will see, if you use steroid appropriately and educate them about what to avoid, then you are likely to treat them properly. Check adherence, appropriate use of medication during follow-up consultation. Don't routinely eliminate food without objective confirmation, starting with your history. So when in doubt, then knock on my door. Thank you. I'm done. Over to you.
Dr. Odusote, for such a lucid presentation. And once again, on behalf of the president and the coordinator, we say a big thank you to you for such a wonderful presentation. I'm going to take the 3 questions or comments we have in the chat box very quickly, and then we'll do a summary of the presentation. Dr. Wizu has asked what your take is. She didn't quite get your take on the use of loratadine as opposed to the H1 type antihistamine. Do you want to take, I'll take the questions and comments very quickly, and then you can respond to them. Dr. Letu has asked a question regarding the number of days it takes to step down from moderate potency steroid to mild steroid. And then there's a third one. I think questions are coming in now. Maybe we should take the first two so we don't get lost in the myriad of questions. Dr. What's your concern about loratadine?
So antihistamine, like I said, doesn't have a major role to play. What you are trying to achieve is to sedate the children. And it's better to use the type 1, like your loratadine. Your fanciful loratadine, cetirizine, loratadine is not going to sedate those children. So it's not useful. I don't use it in my practice at all, but I use type 1 because we want to sedate them. For Dr. Letu's question about steroid, so the thing is, the goal of treatment is to see that if the symptoms is mild, usually I'll tell them use it for 2-3 weeks, BD, and then step down to daily. And what I usually tell them, look at the texture of the skin. Know that you can compare area of liquefaction, inflammation, and to normal area. And say to them, once you are seeing changes looking like this, start to step down and then give a short consultation to review the patient. So there are no other fast rules. So if I'm dealing with very severe disease, I will hit as hard as possible with potent steroid, step down in about 2-3 weeks. I can start with BD to daily dosing and then using fingertip units. And then I'll tell them to compare the normal skin area with the flare of skin area. And you can say tail down. And then you're also available for consultation. You can call me in and they call in or a full consultation and just review or telemedicine. Thank you. I hope I've answered his question, Dr. Letu.
Thank you very much. You have.
Okay.
You did. Then Linda Minja has raised a concern about the food test. Do you arrive at a reasonable diagnosis by just elimination, or do you do a skin prick test? Or do you expose the child to an oral food challenge? And then Dr. Uwe has raised a concern about your comment on non-biologic detergents. Is this a risk considering that it doesn't contain enzyme and is meant to be better?
So what I said, let me take the second question. I said you should use non-bio because bio contains enzymes. So you should use non-bio detergent. That's what I said. So non-bio is your option if you're going to use detergent at all. But what I tell you, if you can use bar soap to wash things that will compare with child's clothing is preferred because you can easily rinse that off. So in terms of food tests, number one, history is key. I said if there's no evidence for IgE reaction to the food, you see hives, angioedema, or flare-up of symptoms within 5 to 10 minutes after exposure to food, there's no need to do a food test because food test is garbage in, garbage out. So I'll tell you a true story. At one of my exams, a child with atopic dermatitis, somebody did a food panel, and the child was reported to be reacting to peanuts, to milk, and to one other food. And I saw the results, and I asked the child, do you eat peanuts? Yes, I do. Is there any problem with peanuts? No. Do you eat egg? Yes. Any problem with peanuts? Your symptom was no. So if you do those tests, and you don't relate to history, so that child, for example, has bad eczema, but he should not eliminate peanut or egg because they are not driving the symptom. The danger of ending those food in that child, see, if your food gets through your mouth, you have tolerance. If your food gets through your skin, then you can have a setup for food allergy. And that's the lesson from LIV study, study that was done about food allergy in the Western world. So the lesson that don't do food panel for anybody except their symptoms showing that they have hives, angioedema, their chest is closed now, flare of symptoms following exposure to food. That's been my response. So I don't routinely do food panel in my practice for atopic dermatitis, except there's strong evidence for that.
All right, so I'm going to take 2 more questions so that we are able to stay on track. And I'm going to take one of the questions from our matriarch, Professor Grange. She's asked about, is the result of skin prick test affected by atopic dermatitis? That's the first part of a question. And then do we have local emollients have we evaluated local emollients like shea butter and coconut oil and other things in as used?
Oh, thank you very much, Ma. If you need healthy skin to do skin prick test. So if you have a child with severe atopic dermatitis, it's not appropriate to do skin prick test on that area of the skin. You must look for healthy skin to do skin prick test. That is mandatory. And thank you very much, Ma, for the question. In terms of evaluating local emollients, there's no study. But one of the things I've been doing, because you find a couple of children that cannot afford the fanciful emollient. The only person I know that was doing some study before she passed on is Dr. Joseph. I think she was doing something, and her daughter is trying to continue that study to evaluate local things. But what I've done, what I have advised my patient that cannot avoid the fanciful emollient is to say, look at Blue Seal Vaseline is a petroleum jelly that more of the fanciful emollients contain petroleum jelly to act as a sealant. So what I tend to ask them to do is to do shea butter that provide original shea butter and do 2 to 1 of 2 shea butter to 1. It's not, there's no SM basis for it. It's just like, I just say, well, let's try it. And without having any results back, some of them are reporting good results and they are able to do it. So it's just something I've done. There's no evidence for it. Maybe if I get funding, I'll study it, but I've advised some of my patients to do that and they've been happy with that kind of, it's just based on basic principle. Most of this thing contains emollient. Shea butter contains a lot of fat and all that, and I think we should do. That's what I've done till date, Ma. Thank you very much for the question, Ma.
All right, I am going to pause on the questions at this point so that we can still keep to time. I'm sure Dr. Elias will be very glad to provide a platform for which some of the unanswered questions can be treated, and he will look into providing a modality for attending to that. But as a way of summarizing from my end, I'll just highlight and 2 or 3 key points from Dr. Odusote's presentation.
Sorry, Yemi, I think Professor James' hand is up. I think she'll allow her to speak.
Oh, I didn't see it.
Yeah.
Definitely.
Yeah,
Prof.
Yemi, we can allow another 5 minutes.
Okay, that's gracious of you. So we'll allow Prof to go ahead first before we. You can unmute yourself, Ma. Prof, I think you're still muted.
Thank you so much. I feel so excited to listen to Dr. Odusote make this presentation. It's been a long time.
Thank you, Ma.
I remember when you took up the challenge of being the first pediatric dermatologist at LASUTH. And we used to look at you like, well, somebody out of space.
Thank you, Ma.
And you yourself, you were not sure which way you were going. I'm so happy that you have now identified even a broader platform with the allegorists or something like that. You are now an allegorist or something. What is it? Allergy.
Allergologist.
Whatever big word it is. Sorry?
Allergologist.
Allergologist. That's right. That's wonderful. I want to congratulate you.
Thank you.
But I'm sad that you did not stick to my former department, at LASUTH. You skived off to Lagos State. Anyway, I'm glad that you're still doing what you are supposed to do, and I wish you all the best.
Thank you, Ma. Thank you very much, Ma. Thank you, Ma.
Thank you so much, Prof. So I'll take 2 more. Dr. Duke raised, there was a question about E45. You want to just touch on that very quickly? And then there's another question I also want you to talk about. And that was the use of the differentiation between seborrheic dermatitis and atopic dermatitis, which is quite another sore point, especially in the early parts of infancy. So those 2 questions, and then I'll hand over the floor back to Dr. Elias.
Okay, let me also, I saw a question by Dr. Waje, which is all very useful. We'll just look at that and just touch on that. Okay,
let's see. Dr. Waje said, can you comment on the combo cream in the market, which is what I talked about earlier, antifungal, antibiotic, and then steroid? We see kids coming in with chemical bonds from this. how long, and then the second part of our question is bleach baths, and what is the dilution? So that's similar to an earlier question. So the combo treatments, do you recommend it? Number two, bleach baths, what is the composition?
Okay, so if I have my powers, those combo treatments should be banned from the market. There's no indication for those combo treatments. And any doctor using those combo treatments is just mentally lazy, that kind of thing. You are mentally lazy, you just observe something will catch it. So ideally, we should push as PAN for this medication. And I'm also talking to my colleague, the NED, National Association of Dermatologists, that we should push for this medication to be banned. No need for it, and it's lazy way of practicing medicine. Bleach bath is what you tend to do is, if you have a regular bath, fill the bath to the level where you have water coming out of that is about 40 gallons of water. You had half a glass of regular bleach, Jik or anything. The rule of thumb is 1 tablespoon to 1 gallon water. So that's the rule of thumb. So what you need to do, they sit in it from neck downwards like they're swimming for 10 to 15 minutes and then have their bath, and that's all it is. But you don't use it for more than 3 days. Daily for 3 days, and that's all you need to do. So you use that if you suspect bacterial infection of the skin. E45 is not a perfect emollient. And I'll tell you what, because the lotion contains a lot of water. So it's not useful. So, but if you want to use an emollient, you must contain some form of liquid paraffin. That means your Blue Seal. So if you had Blue Seal if you add it to E45, you probably achieve better results than using E45 alone. It's not really good. What I tend to prescribe is Hydromol, Epiderm, Epimax, ointments, not even their lotion or cream, because that's not really, what we're looking for, something that will provide occlusion. I guess I've answered all the questions.
All the questions that we can accumulate, there's still a lot more. As I said, Dr. Lutu would be generous enough to.
So you talk about thin line between seborrheic dermatitis and
AD. Yes, maybe take on that as the last question before we.
So like I said, number one, atopic dermatitis, you don't make the diagnosis before the age of 8 weeks. The infantile atopic dermatitis will not itch. The rule of the thumb, it will not itch. It's just the cosmetic appearance. But I will say to you, sometimes there's a thin line between a child itching. So if I see a child that has what looks like typical infantile dermatitis that's itching, and with positive family history, I might tend to think, okay, this might be it. But more often than not, the straightforward infantile dermatitis will have a typical appearance and there's no itching. And that is self-limiting. And then you don't need to do anything. But if they push you to the wall to do something, what I tend to do is mastering activity. What I do, I ask them to use ketoconazole shampoo alternate day. And if there is very ugly looking, I use very mild steroid maybe once the alternate day or 3 days. And without doing anything, it will get better. And that's basically what it is. But itching is not part of infantile seborrheic dermatitis. And that should be the key. For dermatitis, atopic dermatitis, itching is the principal thing. And then it will occur after 8 weeks of life. Thank you.
Once again, Dr. Odusote, thank you for your very lucid presentation. To summarize, the key take-home point, atopic dermatitis is not as rare as it was previously documented in our environment. Number two, the diagnosis is made on clinical ground and is giving us a list of options on how to go about the diagnosis. The third key point here is the quality of life of both the patient and the caregiver must be into. The fourth thing is to avoid unnecessary lab investigation as much as possible. May I also add a fifth one, that as much as possible, treat the patient and not the caregiver. Parental anxiety of the caregiver can push you sometimes to try a list of options. Where you are being pushed, the best option we will say is refer to the dermatologist, and Dr. Odusote will be very happy to have them on in his clinic. Dr. Odusote, thank you once again for the platform. We hand over back to you.
No, let me also tell you, is one of my protege, Dr. Oshinaki, also a dermatologist, hiding under emergency care. So it's in LASUTH. So they want to give that, so you should refer to him also, you can handle those cases. Thank you.
Thank you very much, Dr. Adinake, or Shinake, sorry. Thank you for coordinating this meeting. A special thank you because I called you at short notice, and you did agree and you delivered. Thank you. Before I say anything further, Dr. Mobolaji Lawal, please, do you have anything to say before I give the vote of thanks proper?
No, nothing much really. It's just to thank everyone. This is a record attendance today, and it's not surprising because it's a very, very interesting lecture. I've enjoyed it, and I've learned quite a bit, and I'm sure everybody has learned something very, very important. I thank again Dr. Odusote for giving the very lucid presentation, and Dr. Shinake, and also Professor Grange, and Dr. Okigbo, and also Dr. Ame Idoko was on earlier on. I can see him now. I thank everyone who has been around, especially those who are joining from diaspora, where they have to wake up very early in the morning in order to catch up with us. So thank you very much. Dr. Elite, over.
Okay, thank you very much, sir. Tunde, I didn't expect anything less, so I'm so happy you delivered as promised. And be rest assured, at some point, we'll still call upon you and your team for another presentation. I also want to thank Mrs. Odusote for allowing him to join us. I saw you, I think she's still on to give moral support to her husband. That's very good. Thank you very much, ma'am. The next lecture will be in April, about the 28th of April. We'll advertise the topic shortly. Also to let you know that in the month of May, we expect one of our colleagues in the diaspora to give a lecture. So we want to tap from all over the world the experience, and so that we can give the best care to our children in Nigeria. This lecture will be on YouTube. I think in the next 48 hours after we've done a review, we'll post it. So for those who've missed some part of it, you can watch later on. Thank you very much. Have a blessed evening. Thank you. Bye-bye.
Thank you very much, Sandy.
Good afternoon, everyone. Bye-bye.
Bye-bye.